All right. Good morning, everyone. Thank you for joining us today as we kick off another contract year. As you can see from the slides here, we're calling it COVID is in remission, so the network QIAs are back in commission. That is the extent of our rhyming skills, so please don't expect a verse 2. While we're here on the topic of COVID, I do want to take a minute to thank you all for the last year and a half, what you did for the patients in the facilities. I know especially in New Jersey, it was a very tough year. A year ago at this time was a fairly dark and depressing time to be really anywhere in the world, but New Jersey was kind of a hot spot at that time. And I know your dedication and your hard work saved many patient lives. So thank you very much for all you did and for your dedication during those times. Let's all hope that with the vaccination, which you'll see later, how good the vaccination rates are in our patient population, that COVID remains in remission, and we don't have a wave, whatever that number is going to be, wave 4, wave 5, that does stay in remission, and that we can begin to focus on other topics in the next year. So the agenda for today's call is first, I'm going to go over at a high level the role of ESRD Network 3, kind of how we fit into the federal picture and how we work with Medicare. What our 2021 network QI activities are going to be, or as you fondly think of them as the projects the network rolls out, what the approach to those projects is going to be, the QIA approach. We're going to touch on patient and family engagement, some patient experience of care, high-level overview of the grievance process, and then one of the new topics, it's not clinical quality of care, but is a new topic that we're going to be focusing on, is the EQRS, formerly known as Crown Web, Reporting Timeliness and Data Quality Project, which Tricia Pulchand will be reviewing with everyone. So just to give a quick overview of ESRD Network 3, and before I start, let me just back up 1 second. So if you have any questions, I think everybody is muted by default. If you have a burning question do you want to ask, you can come off mute and ask it. You can also put your question in chat. All the Network 3 staff are on the call and can be responding to you if you throw it into chat. We do have some time available at the end where you can ask questions, but we do value your participation. Please feel free to submit questions in either of those two methods. So the overview of ESRD Network 3, you see here on the screen, we have 3 territories that we cover: New Jersey, Puerto Rico, and the U.S. Virgin Islands. And you see the number of facilities we have, 207 now in New Jersey, 50 in Puerto Rico, and 4 in the U.S. Virgin Islands. And then the total number of dialysis and transplant patients. So we have 14,432 total dialysis patients now in New Jersey. Almost 13,000 are in-center hemodialysis. About 1,500 of them are home on one of the various modalities you see there. In Puerto Rico, we have now over 6,300 total dialysis patients, 5,700 plus of which are in-center hemo patients, and about 600 or so are at home receiving dialysis with those modalities. And in the Virgin Islands, there are no home programs, so we have all 219 in-center hemodialysis. All of that data is current as of about 2 weeks ago, so about as accurate as we can be these days. So just an overview of the ESRD network program. You see this blown out map of the United States. It kind of delineates the network boundaries. CMS uses 2 external groups to ensure that facilities are providing quality, safe, and effective care. The state survey agencies, many of you know the Department of Health surveyors that come through periodically, and then the 18 ESRD networks. I told you earlier, Network 3 covers New Jersey, Puerto Rico, and the U.S. Virgin Islands. Network 4 next door is Pennsylvania and Delaware, and then Network 5 down there in the Mid-Atlantic, West Virginia, Maryland, and DC are all part of the Quality Insights family of ESRD networks. ESRD networks are dedicated to assisting facilities and kidney transplant centers in your efforts to provide quality care for patients with end-stage renal disease. And the bottom line is we support the achievement of the goals that CMS sets forth for us each year in our contract. So some responsibilities that CMS sees that we have is to serve as conveners, organizers, motivators, and change agents. We are asked to leverage technology to provide outreach and education to you. We serve as partners in quality improvement with patients, practitioners, healthcare providers, other healthcare organizations, and other stakeholders, basically whatever it takes to improve the care of patients and make sure that they are receiving the care that they deserve. Securing commitments to create collaborative relationships with other stakeholders and partners. That's kind of a high-level overview of what CMS sees as our network responsibilities. Now, as far as your responsibilities to us, there is a part of the conditions for coverage that you see here. I'm not going to read it, but bottom line is that you are required by the conditions for coverage to have a relationship with the network and to cooperate with the goals and projects that we set forth. Network 3 staff you see listed alphabetically here. We have a couple of new faces. You're going to hear later from Karen Daniels. She is the patient engagement specialist who took Joan Wickeiser's position when Joan retired a couple months ago. And then Heather Cecil is working centrally for us from the office in Virginia, and she's going to be sending out materials related to contacts and data follow-ups. You may have already gotten an email from her asking you to complete the facility staffing so we know who to contact for each of the projects we're going to be rolling out very soon. All right, so here's what you came for. So the ESRD network contract was just awarded to us in late April. The work began June 1st. It's a 5-year contract. It consists of 5 one-year terms or thereabouts, ending in April of each year. So what we're looking at currently is a contract period beginning in June 1st, 2021, and that contract year is going to go through April 30th, 2022. We expect, as long as there's no changes by CMS, that each of the projects and the participants in those projects will likely be reset in May of each year. That's when new baselines will be drawn and new focus facilities will be selected. CMS set forth 5 goals for us in this new contract. These are the program objectives and key results. We're going to go into a lot more detail about each of these, but at a high level, Goal 1 is to improve behavioral health outcomes. Goal 2 is to increase patient safety and reduce harm. Goal 3 is to improve care in high cost or complex chronic conditions. Goal 4 is to reduce hospital admissions, readmissions, and outpatient emergency visits. And Goal 5 is to improve nursing home care in low performing providers. All right, the 2021 CMS goals. First one, improving behavioral health outcomes. We're going to be focusing on depression. So I'm sure your question is, why is this topic included? So in the contract that we received, CMS had what you see here is essentially quotes from that contract. So CMS did a review of Medicare claims data from 2017, and they showed that 12% of prevalent dialysis patients and 7% of incident dialysis patients received mental health visits. However, when they looked at the data that you as providers report to them for depression screening in the QIP, that data showed that only 3.1% of patients were identified as depressed. Obviously, there's quite a disconnect there between that 3.1% and what Medicare claims data shows the reality is in the dialysis population. So CMS is concerned that patients may not be screened accurately or referred appropriately. And indeed, when I go into EQRS and just kind of do a spot check of what the depression screenings are reported as, most of them are negative or the data is not available. So this is something that CMS wants us to focus on by achieving 2 goals. The first is to increase the percentage of patients accurately identified as having depression. And the second one is to increase the percentage of patients when they're identified as having depression who have received treatment by a mental health professional. Obviously, there are numeric goals attached to that. We do not have baseline data yet to see where we stand as far as by territory or by ownership or by facility. So for all these projects, we have not really chosen any kind of baseline target facilities. We kind of have some indication for some of them about which facilities may be in it. But for all of this, once again, we do not have any kind of baseline data to begin to roll out these projects. The second topic, improve nursing home care in low performing providers. Why is this topic included? Probably don't need to tell you, you've all experienced it firsthand. The lessons we learned from the COVID-19 pandemic. the nursing home population was really hit very hard. And because of that, it really got a lot of national attention. I think in many ways that population has been ignored to some extent. So CMS really put a focus in this new contract on protecting those vulnerable populations, the patients who live in the nursing homes, and specifically, they are focusing on patients who receive care in the nursing homes. So it doesn't happen in any of our geographic areas, as you see in that last bullet there, but in other states in the country, there are a lot of patients who stay in the nursing homes, and essentially dialysis staff come to them to provide on-site care. So for those patients who are receiving care in the nursing homes, the goals are to decrease the hemodialysis catheter infection rate in those patients, to decrease peritonitis incidence, decrease the rate of dialysis patients who receive a blood transfusion. So three goals really focusing on those patients who receive care in the nursing homes. Now, I know that there are entities who have tried to begin to do this in New Jersey, especially, and the state licensure process right now is prohibiting that. It's been going on for several years now, trying to negotiate and see what can be done to, rather than transport patients back and forth from the nursing homes, just go directly to the nursing homes and provide care there. But we do not have any kind of ETA on when that might be allowed in the state of New Jersey. So we have brought that to CMS's attention. They may change this project a little bit to focus on patients who live in nursing homes and uh, transport to the dialysis center to receive care there. But as it currently stands, and without a change from CMS, we would not have any patients or by extension facilities that would be eligible for participating in this project. And you can celebrate at this point if you like. The next topic is to improve education and access to empower patient choice of home modality. This is really a continuation of what we've been doing for the last several years with focusing on home dialysis. And I put in the most recent data we have because it shows that in New Jersey and Puerto Rico, we have really shown a significant increase in the last year. During 2020, we really saw a lot of patients change to a home modality. Why is it included? CMS sees it as enhancing patient quality of life, better blood pressure control, fewer hospitalization, and it's really a priority of the new payment models that CMS has rolled out called the ESRD Treatment Choices, or ETC, and executive order that was signed a couple of years ago called the Advancing Americans with Kidney Health order. Those of you who are in the southern New Jersey area, sort of Camden County, even some areas of Burlington County, you may have already been told that you're in the mandatory ETC model. And by extension of that, you may already be working very hard because of your corporate focus on improving the number of patients who are receiving care at home and receiving a transplant or getting waitlisted. If not, you'll be, if a low performer in the project and in the participants that we select to achieve the CMS goals. But I just want to focus for a second on the chart at the bottom just to show you, New Jersey is now at 10.5% of all patients receiving care at home. Puerto Rico is now at 9.2%, which is really, look at the bar, how high it is compared to 2019. But if you kind of let your eye drift to the right, you can kind of see that we're still well behind where the US overall is. Even back in 2016, the US overall home modality percentage was at 12%. So we're still, locally in network 3 behind where the entire country was 4 years ago. So we do have some ground to make up, but if we can continue to proceed at the rate we did last year, we will catch up in very short order. So what are the goals? Do we want to, first of all, increase the number of incident patients who start dialysis using a home modality by 10%? So according to the 2728s that we received last year, almost 5,000 patients started dialysis in New Jersey, Puerto Rico, and the U.S. Virgin Islands, and 482 of them began that dialysis at home. So they never experienced in-center, they were trained, went directly home. So the way the CMS math works, 10% is not getting from 9.65 to 19.65. It's 9.65 plus 10% of 9.65. So this is my, back of the napkin math based on that. We've not gotten, like I said, the official baseline data or any kind of target facilities or goals from the NCC or CMS yet, but if the numbers that I have are the numbers that they have, the theoretical goal will be somewhere around 10.6% of the new patients between now and April 30th, 2022, starting dialysis at home. That would be the goal. We need to increase the number of prevalent patients who move from in-center to home by 2%. Once again, the same math as above. It's not like we have to increase by 2 percentage points. It's 2% of whatever number of patients moved home last year. And then increase the number of rural ESRD patients using telemedicine to access a home modality by 2%. As you know, there's not a whole lot of rural areas in our geographic areas. As a matter of fact, I'm not sure that any of our zip codes qualify officially on the federal websites as a rural zip code, so we may not be eligible for that particular goal either. The next one is to improve education and access to empower patient choice of transplant. So once again, a continuation of what we've been focusing on for the last couple years. Why is it included? Obviously, better quality of life. It's a cost savings to the Medicare program. If a patient has a transplant and it lasts for 3 years, it becomes a savings to the Medicare program. The transplant is then much cheaper than dialysis. I believe the latest estimate I've seen with the annual cost to the Medicare program for dialysis is about $85,000 a year. And then once again, it's a priority of the new payment models, ETC and the executive order AAKH. That AAKH directive had a goal that 80% of the new patients in 2025 begin dialysis at home or receive a preemptive kidney transplant. And I'll remind you that 80% is a long way away from where we are currently. You saw on the earlier slide the number of patients who start dialysis at home in 2020 was 9.65. I will tell you that we had, I believe, 58 preemptive transplants in Network 3 in 2020. So, we may be at 10%, we're certainly not at 80%. So quite a ways to go to achieve that national goal. So the first year goals for the transplant activities is to, first of all, increase the number of patients added to a kidney transplant wait list by 2%. So in 2020, we had 695 patients on dialysis in our 3 areas that were waitlisted. So once again, back of the napkin math, the theoretical goal for this coming year would be to add 709 patients to a wait list by April 30th of next year. Once again, we believe that the same criteria we've been following for the last couple of years with this project will apply here as well. And that is, it doesn't necessarily need to be the patient's first waitlisting. If they're already waitlisted locally, they can be multi-listed somewhere else, and that will count as a listing. Most times that does increase a patient's chances of being offered a kidney and receiving a transplant. There are some changes to the kidney transplant allocation model, which is putting that a little bit into question. But the latest guidance we've gotten from St. Barnabas is that if the patient is multi-listed at another center that's more than 250 miles away from the first center they were at, you still mathematically and statistically increase your chances of receiving an offer. I will tell you there's a program coming up that St. Barnabas is putting on later this year where the allocation model and the changes to it will be highlighted. So those of you who are transplant designees, I'm sure you'll be hearing more about this if you've not already. The second goal, which is new to us and is going to be a bit of a challenge, as you can imagine, is to increase the number of patients receiving a kidney transplant by 2%. So in 2020, we had 58 patients receive a preemptive transplant at New Jersey or Puerto Rico dialysis centers, and 600 patients received a kidney transplant after being waitlisted and receiving a kidney offer. So once again, back of the napkin math, the theoretical goal would be 670 patients receiving a transplant between June 1st of this year and April 30th of next year. Doesn't seem like a whole lot more, just 12 more, but all of you know some of the challenges with increasing that even a little bit. So we shall see how that works out. The next goal or the next project is to educate and manage the incidence of COVID-19 and decrease hospitalization of COVID-19 positive ESRD patients. Thankfully, this has kind of met a natural goal. That first one, decrease the number of COVID-19 hospitalizations in the ESRD patient population. Um, but the second goal that we're still working toward in most of the areas that we cover is that CMS expects a minimum of 80% of ESRD patients receiving dialysis to be vaccinated. So you might ask, where are we currently? So as of yesterday, here's what we have. So I put patients and staff fully and partially vaccinated rates on here. You see that New Jersey is getting very close to that 80% for patient vaccinations. Puerto Rico has already exceeded that. Puerto Rico is already at 86% of the patients fully or partially vaccinated and 90% of staff. Even though there's not a staff-related goal, we do monitor that. Many of you may know that you report that data each week to NHSN, and this is the results of what was reported up through yesterday. The Virgin Islands kind of fluctuates because of some reporting issues. Right now, they have 55% of those 219 patients you heard about earlier that have been fully or partially vaccinated, and about a third of the staff have received their vaccination. So I just put a little celebratory confetti blower, whatever that thing is, next to that staff number because it is one of the highest in the entire country in Puerto Rico. Both the patient and staff number is among the highest in the entire country. So in addition to the COVID-19 vaccination, there are some additional goals for other vaccinations. First, the flu vaccine. The goal is to ensure that 85% of dialysis patients receive a flu vaccine, and a minimum of 90% of dialysis facility staff receive the flu vaccine. The first will be reported in EQRS, we hope, at some point when that clinical reporting is opened up again by CMS. And the second one, the staff vaccination, will be reported through NHSN data. I will say that for the 2020 flu season, we got very close. I believe we were at 85.5% or 86% of the dialysis patients who received the flu vaccine. I suspect it was probably higher than that. The clinical data being shut down for such a long period of time prevented a lot of facilities from submitting the last quarter of the flu season vaccination. So I suspect we're probably in excess of 90% if that data had been complete. We also have some goals for the pneumococcal vaccination. The first is to ensure the eligible dialysis patients receive the PPSV 13, and then the PPSV 23 as well. This is one that we ran a couple years ago. I want to say 5 years ago or so. This data will be reported through EQRS. We're going to be tracking it there. There was a lot of, if I remember correctly, some data issues with who's eligible, which series they've gotten. So we're going to see if the data is a little bit more clean this year. As I said, we have not received pneumonia data for quite some time now, so we have no idea what our baseline rates are, who the focus facilities might be, et cetera. But we hope to get that sometime in the next several weeks. Okay, here's one that's going to be probably an uphill fight for us. We have not in Network 3 focused on reducing hospitalizations in the past. There have been a couple networks in the country who have chosen that as their optional project. We ran the VOC Rehab optional project in the past. The networks who have run this have not been successful in reducing hospitalizations. As a matter of fact, once they get through trying to get the data accurate, they realize that they actually end up with a higher rate than they began with because it turns out there's a lot of this data that isn't reported in EQRS. So CMS plans to use claims data for this. We know there is a delay in Medicare claims and the ability to get to that and be able to real time and in an agile way adapt to what the challenges might be. But here's what CMS has set forth: reduce hospitalizations, reduce unplanned admissions, and reduce outpatient emergency room visits, as I said. So CMS does not necessarily expect us to reduce all hospitalizations. They're really focusing on ESRD related. So they're going to be looking at specific primary diagnosis categories for the admissions and see what we can do to address those. I'm certainly not going to read through all of these primary diagnosis categories. There are 26 of them that CMS included in the contract. This is what they'll be pulling for the baseline. This is what we're going to be asking you to focus on. This is what we're going to be measured on going forward in the next 10 months or so. So we do not have, as I said, a whole lot of data to be able to tell you, how many hospitalizations there were for the population. But what we did was we went to the dialysis facility reports that each of you received in July, just to see where we are in the Quality Insights family of states. So you see on the left, we have New Jersey, Puerto Rico, and the U.S. Virgin Islands. Now this is all risk adjusted. So the standardized hospitalization ratios say, what is your patient population? What are their characteristics? What are their comorbid conditions, ages, et cetera? And based on that, statistically, how many hospitalizations would be expected in that population? If you were expected statistically to have 10 and you had 10, your ratio is 1. So obviously, if you have fewer, your ratio is less. If you had more than statistically expected, you would have over 1.0. So you will see here that New Jersey has a very good standardized hospitalization ratio. I believe in the next week or 2 weeks or 3 weeks, you'll be getting your new DFRs from the USRDS and UMCEC. So I urge each of you to take a look at that, see where you stand with this. You see the New Jersey ratio is right at 0.95 or so, I would say, judging by that blue bar, ticked up a little bit. Puerto Rico is about 40% higher than statistically expected, and the Virgin Islands has a little bit of noise because of the small number of patients down there, but they do very well according to the data that's in the DFRs. Same thing for the standardized readmission ratio, or the SRR, although in this case, we're all above that 1 in New Jersey and Puerto Rico. Not much. New Jersey is just slightly over 1. Puerto Rico is around 1.2. The Virgin Islands, once again, is kind of all over the place because of the small number of patients. But this is what was reported in the dialysis facility reports, table 4. You see footnoted there in that DFR. And then the hospitalization ratio for emergency department visits. You see New Jersey is not only doing well, but improving each year, slowly ticking down. Puerto Rico also does pretty well here, as does the Virgin Islands. So across the board, pretty much all the states in the Quality Insights Network 3, 4, and 5 do pretty well. West Virginia is kind of an outlier, as they are with many things. All right, I'm going to turn it now to Annabelle Perez, who is going to go over the QIA approach that we're going to follow for this contract year.
Thank you, Chris. Do you want to continue to move the slides along for me?
Sure. Yep, I can do that.
Great. So next slide. And I just want to echo Chris's appreciation for all you did in the last year and a half with this COVID pandemic. But I do admit that I am excited to get back into the work and work closely with you moving forward. So I know that you probably have mixed feelings about it, but I think that for us at the network, we're excited to work with you again closer. So just to follow the QIA approach, ESRD networks have been tasked by CMS to drive improvement at different levels. We will continue to integrate patients every step of the way, beginning with the network level, with advice from leaders and experts from our advisory committees, at the community level through community coalitions, and at the facility level through individual technical assistance. We will approach each level using a barrier identification and mitigation approach. Next slide. So for the advisory committees, we brought together experts, dialysis staff, corporate leadership to participate in advisory committee meetings for each of the QIA topics Chris just introduced. The goal for these was to prioritize barriers and discuss strategies that the network could further develop. So as we implement these new quality improvement activities, please be assured that the interventions we will promote likely originated from best practices presented by this committee. And CMS expects that peer mentoring, establishing a meaningful plan of care, and patient participation in quality improvement at the facilities be included in the strategies we choose for the different QIA topics. Next slide. So we will be identifying existing and or developing coalitions for each of the topics in the network QIA. The goal is to focus on geographic areas of most opportunity and identify and address local issues affecting progress in the topics of opportunity, such as home transplant, hospitalizations, etc. And just so you know, facilities with high perform or what we call high performing facilities may be invited to share promising practices at these coalitions. Next slide. So for the targeted technical assistance at the facility level, we will provide data-driven targeted technical assistance, and we'll be spreading best practices to support the facility's efforts to improve. It's important for you to read our emails and respond to us timely. So we want to work with you. We want to support the efforts that you're already putting in place. And we look forward to working closely with you and actively. Next slide. So as you may have noted, we have not mentioned the number of facilities to be included in each topic. And Chris explained that we have yet to receive baseline data. But another reason is that CMS has shifted to look at improvement at the network level. And as a result, all facilities are considered to be in the network QIA. However, the number of topics in the network QIA that you will have to work on will depend on your facility outcomes. And Verna will be covering the communication of the baseline reports and the reporting requirements in more detail in a few minutes. But our expectation is that the facility approach the network project as one and work together on the required topics, as many of these go hand in hand. We ask that you review and discuss each topic you are deemed needing improvement for based on the baseline data we receive during your quality meetings, and together discuss the barriers and establish plans for improvement. We recommend that you identify topic leads that will follow up on the activities and the interventions for each focus. So as I mentioned, we expect active participation in the network-led activities, and please don't forget to let us know if there are any key personnel changes. Now I will pass it to Verna, who's going to cover the QIA reporting. Unmute yourself, Verna.
Good morning, everyone. Thank you all for joining us today. And thank you, Annabelle, for explaining the network and facility QIA approaches. So network QIA comes with reports and reporting, so we could monitor and track activities and progress towards achieving goals. So at this time, I will give you a rundown of these items. First off, we have the facility baseline report. This facility baseline report identifies facility areas of opportunity for the 2021-2022 contract year with individual facility goals. This report will be distributed via email to all facilities as soon as data becomes available from the ESRD NCC. We ask that you review this report with your interdisciplinary team and note the topics your facility needs improvement, so keep an eye out for this. Next is we have the area of opportunity acknowledgement. After receiving and reviewing the baseline report, you will be asked to acknowledge the areas that your facility needs improvement through a reporting link that will be included in the email when the facility baseline report is distributed. This acknowledgement includes identification of barriers and facility action plans to achieving your goals. This is completed only once at project enrollment. Next, we have the status check form. This will be used to follow up on barriers and actions taken by the facility among defined areas of opportunity, and this will be completed monthly. The outreach coordinator will send the reporting link via email to you. And if reporting deadline is missed, facilities will be notified to submit. Next, we have the root cause analysis, or the RCA form. This will be completed as indicated only based on facility performance to individualized goals. A facility identified as not maintaining stability or forward progress will be asked to complete this report. And finally, we may need additional information regarding certain topics, so facilities may receive email surveys as well. Next slide, please. So Once the baseline reports are distributed, this will be our next steps. Facilities will initiate reporting of the area of opportunity acknowledgement and the monthly status check. Next, to streamline reporting, unlike previous years, there will be one reporting link for all topics in the network QIA. We highly recommend designating one facility representative to submit monthly reporting for all the QIA topics. This representative will coordinate the facility QIA activities with topic leads. And as Annabelle has mentioned, this will be done during your quality improvement meetings. Have a backup plan in case your representative becomes unavailable. And finally, if you have not responded to the 2021 environmental scan, please do so by June 30th. Your responses will help us identify facility needs and will enable us to provide you with targeted assistance. Only one response is required per facility. Thank you for your attention, and we look forward to working with you all. I will now turn the presentation over to Jesse Cubillo. Thank you.
Cubello? It's Cubillo, Berna.
I'm sorry.
No, I always joke. Everybody calls me Yossi Cubello. Thank you, everyone. I appreciate having you all join us today. And of course, I'm going to speak about my favorite topic, improved patient and family engagement at the facility level. You all know I've worked at one point or another with all of you with this topic, and we've implemented different sections of patient and family engagement at your facility that has improved over the years. Chris, if you don't mind going to the next slide. So the goals that CMS has set for us in this new contract are focused in three main areas. The first one is successfully integrating patients and families into QAPI meetings. One of the things I've always liked to brag about is how our network, being New Jersey, Puerto Rico, and even the Virgin Islands, has been very successful in the past few years in integrating patients and families in your facilities QAPI meetings. And this was something that we initiated voluntarily, and you guys took on that initiative and started making changes that CMS was yet to implement at the level that we're finding nowadays. And so here today, now CMS is actually implementing and requesting that facilities start integrating patients and families in the QAPI meetings. Therefore, you find yourselves having an advantage because you have already worked in this task and have some of the tools that we shared with you in the past. But I look forward to kind of bringing that back to life. I know 2020 a hard year for everyone, and some of these initiatives that we worked on to kind of sustain in previous years have kind of fallen to the waste side. So I look forward to kind of bringing that back up again with your facilities, with your partnership. And as I always mention, this is not just the sole responsibility of one person to complete at the dialysis center. This is the responsibility of a team effort. So the interdisciplinary team, the techs, nurse, everyone at the center is the full responsibility of having that integration and participation and welcoming those patients and families in your QAPI meeting. So this is just a brief overview of what's expected to come. Stay tuned for more information in regards to the projects that we're doing specific to that topic. The second topic that we will be working on is developing a life from which the dialysis centers use to create the plan of care. I did send everyone a survey earlier in the month, and that survey was to kind of assess how many of you were integrating patients in these three areas that I'm covering right now, and to see where you're at this point. And if you have not had the chance of completing survey came directly from me, please take a minute to complete it so that I can have a better understanding of what's going on, because it would help me provide you better support as we move forward. I know the concept of a life plan is fairly new. It's new to everyone. It's something that CMS kind of put into our contract. There are tools that we've identified that facilities have not used yet, and so we're looking forward to kind of implementing those tools and sharing those tools with you all, so that you can better improve, not better, but to improve the process that you have with your patients in developing their plans of. I had a discussion with the facility in regards to the life plan and what's the difference between the life plan and the plan of care. Life plan comes more from patient's perspective. What are the goals of the patient? What is it that the patient wants to achieve? And it's more geared and developed by the patient compared to the life plan that's more facility focused into what the facility is looking forward to achieve with the patient and how we can help the patient achieve those goals. So I think the two will marry each other, and the tools that we are looking to provide you with will be very helpful in kind of supporting what you're already using in pair with what we will be implementing in the coming year. And the third section that we will be working on, which is brand new to everyone, is peer mentoring. Reason I say is brand new, I know we talked about peer mentoring in the past. It was an official format that many facilities have peer mentoring at the dialysis center. We talked about even family members being a part of groups in the lobby. But this is the reason I said this is brand new is because there is an actual program that CMS has provided to us that will standardize the whole process of peer mentoring at the dialysis center, and we are going to then we're going to oversee this program, this process that you will follow at the dialysis center to recruit peer mentors and to provide that opportunity of mentoring to other patients at the dialysis center. Very excited about this program. To me, this is kind of like when we started working with patient engagement in QAPI many years ago, and it was a whole new concept, and everyone was kind of adjusting to how we're going to do this, how are we going to start adjusting and bringing our team to be more pro QAPI participation. Well, the same thing is going to happen with this peer mentoring program, and how we are going to sustain that process going forward is going to be very interesting. So I look forward to sharing more information in regards to that in the near future. Next slide, Chris. Some of the reporting that I wanted to share with you briefly that we will be requiring of you who participate in these three sections, these three areas. For the QAPI meeting, as you're familiar with how we did Beyond Engagement in the past, there was a link where you go in and kind of report if you have patients participating in QAPI meeting. There's going to be something similar to it, and we're calling it Empowering Partners for Improved Care. Every facility will be required to, who's participating in this project, of course, will be required to go on a monthly basis, even if you didn't have patients participating in QAPI, because we want to be able to understand what are the barriers you're facing, how we can help you overcome those barriers. So every facility will be required to go into this reporting on a monthly basis and say, yeah, if I did have, then share with us what is it that you did. The idea is that this report will then be able to help you demonstrate that you have patient participation in your QAPI meetings, and adds to the discussion. Just like the social worker has a section to discuss in the QAPI meetings, the administrator, the dietitian, everyone has a part. This will be the part that you can kind of integrate in your QAPI meeting minutes in a formalized manner. So I'll share more details in the future in regards to that as well. The second component is developing a life plan and adapting those tools. We are still kind of putting together the way we're going to track this. Oftentimes, the way we're able to kind of work with facilities one-to-one was during facility visits. I personally am very much looking forward to starting to do the facility visits because I get to see you all one-to-one. I get to speak to your personal needs as a facility. What are the challenges you guys are working on that you're facing, and how we as a network can support you and provide you the support and guidance that would help you overcome those challenges and meet the goals that Annabelle and Chris and Verna just finished kind of explaining. Because at the end of the day, as I mentioned, patient engagement is the foundation to everything that we're doing, and that's how CMS is looking at it, and that's what they're reinforcing this topic. So plan of care and the life plan, when we either do virtual meetings with you one-on-one, Zoom calls, or facility visits, we'll be able to provide your support and talk a little bit more further into the processes that we'll follow for this task. The third one is developing and supporting the peer mentoring programs. I've mentioned CMS has put together a program where we will work with the facilities to identify, recruit, and refer peer mentors so that they can be able to be a part of this program. There will be training provided to these peer mentors. Yes, the network will assist the facilities. You don't have to worry about doing that training yourselves. We will provide that training for those peer mentors so that we can coach and help you have a better put together peer mentor in your dialysis center and be able to provide adequate support to patients who are in need. And we will what we would need from you guys will be kind of interactions that are happening in the center, and of course the support that the patients may need as they move forward with this peer mentoring efforts. Overall, these are the three topics focusing on when it comes to patient engagement, and as I mentioned, these will be the foundation for the goals that Annabelle, Chris, and Verna can just share, and we look forward to kind of putting all these together, bringing back efforts that you already had been working on, and kind of starting with a new look at how we're going to do things with patient engagement. So I'm very excited about that. Now I think, Chris, if you go to the next slide, it's patient experience of care. I'm very excited to introduce our new patient engagement specialist, Karen Daniels.
Good morning, everyone. As Chris mentioned in the beginning of the presentation, I have stepped in for Joan Wickheiser, who has been with the network for a long time. So I'm looking forward to partnering with everyone as they navigate the complicated grievance process. I'm here to support and guide you with any questions and concerns you may have. Next slide. So as we know, with the conditions of coverage through CMS, every dialysis clinic is required to have a grievance policy. All patients must be informed that they have the right to file a grievance without any reprisal or refusal of care. And an anonymous grievance process must be established, and patients must be informed of the process. Units should place the facility grievance process in their waiting room. I can't see this. So patients need to be informed of their rights to file a grievance without any reprisal, be informed of their internal grievance process, and that there's an anonymous process. They should be provided with the phone numbers for the network as well as the state agencies, and facilities should be clear of what their processes are and make sure that's communicated to the patients. Next slide. And this is the patient grievance handout that should also be posted in your waiting room with the phone numbers and clear instructions on how to file their grievances and what their rights are and what they're protected about. And I'm going to hand it over to Trish, who's going to talk about data.
Good morning, everyone. I think most of you know me. Tricia Polchan, I'm the regional data manager here at the network. I'd like to reiterate the statements that have been made by our staff, and thank you so much for all of your hard work and continued dedication to our dialysis patients over what can only be described as one of the worst years in recent history. So as all of you are aware, we have experienced some bumps along the data road with the rollout of EQRS. But even before that, and before its implementation, we saw some issues that had been occurring for several years. We saw that admissions were not being completed within 5 days. They were late 2728 and 2746 forms. Additionally, the help desk has received an increase in requests to make changes to submitted 2728 and 2746 forms. I think that it's a combination of all of these things that has caused CMS to focus once again on accuracy and timeliness. Chris, next slide, please. So based on that information that I just shared with you, CMS is reinforcing or refocusing on these goals. Patient admission records entered within 5 days, completing your initial CMS 2728 forms within 45 days of a patient arriving at your dialysis facility, completing the 2746 forms within 14 days of a patient's death. And then, of course, all around ensuring data accuracy in EQRS. Next slide, please. Okay, so everyone's fears, what am I expected to do? Basically, we would require that facilities participate in any network-led technical assistance activities. We will be receiving data from CMS to identify any facilities that are low performing in regard to getting the admissions in, getting forms in on time, and so forth. As part of that, we will be requesting patient records to review just to ensure that the data is accurate. Now, also, we will be asking the high performing facilities to possibly share some best practices or anything that they've learned over the years that could assist folks in meeting the data requirement needs. Next slide, please. Okay, so of course, you know, they did save the best for last, which was me. We now have just, if there are any questions, I know that we've asked you to put some things in chat, as well as just to at least provide you the breakdown of the topics and the projects we've discussed with all of our contact information. So thank you so much again for joining our kickoff call. And I'll hand the ball back over to Chris.
Thank you very much, Trish. Does anybody have any questions that they'd like to ask verbally? You can come off mute if you do and ask that. I don't see any questions in chat yet, so I'm guessing you're either in stunned silence or none of this is really a surprise to you. I know much of it is really in line with what CMS priorities are for sort of national programs. So those of you who belong to corporations, Fresenius, DaVita, DCI, USRC, ARA, DCI, if I didn't say them already, you know, you may have already heard about a lot of this from the corporate initiatives and priorities that you have for this year. But if not, you have here on the screen who the leads are, as Trish mentioned. Do have one question about, do we have a date when the website will be opened up for data submission? Annabelle, we don't have a date yet for that, do we?
No, we don't have a date for that. We will not be asking anyone to report anything until we are able to provide you with a baseline report so you can see what areas you're considered to be needing improvement in. So that'll be the first thing. You will receive a baseline report. In the interim, you may have noticed that some of us have been emailing you directly, just trying to head off the work with reviewing some of the data reported in the DFR or the UNOS data for transplant. So we are working individually with some of the facilities, but until you have a baseline report that can provide you the areas, and I just saw that she's looking about, she's specifically asking for clinical data in QRS. Yeah.
Yes, so the clinical data in EQRS, if you are a gambling person, feel free to set your bet out there. We have really no idea right now. I know that the entities that report data electronically to EQRS, DaVita, Fresenius, DCI, and the NRAA, which kind of submits data for a lot of different entities, have been working twice a week calls with CMS, testing. There's sort of a test version of EQRS is set up where they're trying to fix some of the things that were broken when EQRS was released in November. I believe they're on round 3 of that testing, which is due to end at the end of June. If that all goes well, theoretically, CMS could open it up again in July, but we have not got any kind of firm date whatsoever. And I would not be surprised if it stretches to August, September. Rest assured that when it is opened again, CMS is not going to set any kind of tight timelines. We've made sure that we let them know that there are a lot of entities that have to manually enter this data. So, you know, keying in lab values for months and months and months is going to be a tedious and time-consuming task, and we made sure that we let CMS know that. So you're probably going to be, when CMS does open it up again, you're going to be getting communication from Trish, as well as from the OCT team, that sort of My Crown Web email that goes out to let you know what changes are coming. And we hope there's a timeline that's reasonable to make sure that you have time to get it all in the system. Trish, I'm sorry, Jesse, there was a question about patient engagement. Did you see that?
Yeah, So to answer the question is, when we talk about patient engagement and peer mentoring, are we taking into consideration how clinics are managing visitors to the clinic, including having families come into the clinics? I'm guessing the question has to also do with how we've been responding to COVID-19 and the guidance that has been put in place that has kind of hindered some of the efforts that you've initially had in the past for integrating patients in QAPI and doing peer mentoring in the facility. We are taking that into consideration. We're looking at different ways that you can do peer mentoring, not just, it doesn't have to be in person, but having that patient engagement and that communication can be via a Zoom call, could be virtually. But yes, we are taking into consideration all the, as things change, the requirements and everything that you as facilities have in place so that you can continue doing patient engagement, but keeping in mind that each facility has their own level of safety that needs to be followed. So yes.
And Chris, if you don't mind, I'd like to jump back in regard to Tumi's question about the clinical data submission, especially for our independent facilities. I would highly recommend, I know that in speaking to some of you when we were trying to gauge as to what may be expected once that data entry is allowed once more, that I'd hope that you streamline all the data that you have to submit, so that if you can go to, say, patients A through Z and actually go through, what exactly is necessary that you need to submit, that it's all in one location, so that when the time comes, it'll make things easier for you to go into that clinical month and you can put in Jane Doe's and you have everything right there, as opposed to having to dig through records and charts. So I know that would be a project in itself, but I think it will assist you in streamlining a process or easing the submissions once they're put back into place. All right.
Thank you, Trish. Matthew Berkowitz asked about the research literature and depression. Karen, do you have any feedback on that? I know you're.
Yeah, so right now, some of the team in Network 3, 4, we are going through databases. We're trying to look into partnerships and coalitions with patients, with people in territories that also have similar issues right now, and seeing if we can find individuals that are open to providing assistance with patients that have no insurance, and see if there are any clinics that have that available. And then we're just talking behind the scenes, and it's one of the goals that we're trying to do, is see how we can bring the expertise of the people already doing the work in the clinics, and see if there's any ways that we can align some of the goals with that. So that's part of this project, is really kind of developing platform right now for the underserved, as well as those that have access to care.
I see that was Ruby's question, not Matthew. Sorry, Ruby. There was also a question about whether or not we're going to share these slides. We can do that. What I'm going to do is put a nice fat date on the title slide. Reason being that this is what we understand to all these issues to be, all these projects to be today on June 24th. But if history is any teacher at all to us, it is that much of this can change. So we know that there are, as Trish mentioned, some issues with EQRS that might affect the data for some of these. There's also some issues with claims data and things like that that might impact some of this. So things are subject to change, to say the least. So we'll make sure that we put a date on there. The reason I say that is a lot of times when it gets shared around, people that did not attend this may not have heard those disclaimers. So what you see may not be exactly how things are run when the project actually begins. But yes, we will send out the slides for your reference.
And Chris, I'd just like to add that we will also send a link to the facilities that are not represented on this call, because we want everyone to be on the same page as where we are currently. Of course, we will inform everyone if anything changes for any particular topic in the QIA. But we can email those that are in attendance and share them share the slides, and we will have a link for those that are not on the call, and request that they do listen to the recording and attest to having completed or attended the recorded webinar.
Okay, I'm not seeing any more questions in chat. Does anybody else have anything that they'd like to have clarified for them? Anything that was surprising to you? Once again, you can come off mute if you would like to just ask rather than type it into chat. I think everybody is seeing an extra half hour that they might be able to get back in their day.
Well, Chris, I'll just tell everybody, feel free to reach out to any of us. We are here to work with you. I know that your corporations have a lot of resources available for you, but every now and then you may just want to reach out to us for any additional tools or resources that you may be trying to find and are not able to. So look at us as a resource. We're here to work with you and just help you do what you're doing, which is trying to improve in all of these areas that we've covered today.
All right, thank you all for attending, and have a good rest of your day and a good rest of your week, and we'll be in touch very soon. Thank you all very much.